Hi, good morning, and welcome to Grand Rounds. We're really privileged to have Charles Powell with us today, who is the Janice and Coleman Rabin Professor of Pulmonary Medicine at the Icahn School of Medicine at Mount Sinai, the System Chief for Pulmonary Critical Care and Sleep Medicine at Mount Sinai, and also the Chief Executive Officer of the Mount Sinai National Duris Health Respiratory Institute, and the president-elect of the Fleischner Society for Chest Radiography. Dr. Powell received his Bachelor of Arts from the University of Pennsylvania and then his MD from the University of Chicago, and then completed his internship, residency, and chief residency at Columbia University Medical Center, followed by a fellowship and then a research fellowship in pulmonary medicine at Boston University Pulmonary Institute. And started his early career as a junior attending in Boston, but then came back to New York and had a substantial portion of his career at Columbia. Going all the way back 20 years to Dr. Powell's very first published article and the more than 100 articles and book chapters and monographs since then, he's become and has focused on lung cancer and the whole broad scope of lung cancer. Thinking about screening, for example, and risk stratification, including as it relates to women and people of African American heritage, thinking about the molecular signatures of typical tumors and also unusual tumors, thinking, of course, about treatment modalities and long-term complications of those treatments, things like palliation, the whole scope of lung care. And he's had such excellence and is such an expert in that field. It's really wonderful to have him here today to talk about his expertise. Separate from that, and really the way I know Dr. Powell best at this point, is he is a champion for patient care. And by way of the Sinai Respiratory Institute, has focused on the efficient delivery of care, multi-specialty care and access to that care for patients, and the physical environment in which that care is delivered. And I think in that way, he really is a special and unique person for all of us in what he's trying to deliver for his patients and serves as a model for that. Cap, it's wonderful to have you here today and welcome.
Great. Thanks very much, Sam, for that really kind introduction. Pleasure to be here. Hello, St. Luke's. I have a special affinity for St. Luke's. I was born there. And I also have affinity for Mount Sinai West. So for disclosures, I have consultant relationships with 2 companies. I'm not going to talk about them or their products. But I am going to talk to you about lung cancer screening and about precision medicine as it applies to lung cancer. So I think it's always important to set up the nature of the problem, and so we all understand the gravity of the issue. And so for lung cancer, it's not difficult to convince you about the gravity of the issue. Every year, there are going to be 220,000 people diagnosed with lung cancer. It's not the most common cancer. Prostate cancer is more common in men, and breast cancer is more common in women. But more people die from lung cancer than those cancers. And you can see lung cancer is the #1 cause of cancer death in both men and women. And that's not just in the United States, it's in the world. And in fact, if you sum up the number of people who die every year from prostate, colon, and breast cancer, that total is less than the number of people who die from lung cancer every year. So why? Why is there such a difference in the number of people who die from lung cancer compared to other cancers? So here is the trend in 5-year survivals over the last 35 years for the 4 common cancers that I just mentioned to you. And you can see in the blue line that prostate cancer 5-year survival has increased dramatically over the last 30 years, and statistically is about 98 to 99% 5-year survival for prostate cancer. Breast cancer survival also has increased. It's up to about 85% 5-year survival, and colon cancer too has increased. It's over 65% now. So contrast those 3 lines at the top with that flattish yellow line on the bottom. And that yellow line is the 5-year survival for lung cancer. which has gone from about 12% to approximately 19% now. So we have to think then, what might be some reasons for what we see as this discrepancy between the survival rates for lung cancer versus the survival rates for prostate, colon, and breast cancer. Anybody have any idea or suggestion? A hand in the back.
Your lungs are very large.
Uh-huh.
So it's a large space for the cancer to grow before you start having symptoms. So it might be that they present much later in the disease, and the time it's later, it's harder.
Excellent, right. So late detection. Almost half of lung cancers are detected at stage 4 metastatic disease stage. Exactly. That's good. So that's one, and there's one other one.
Inadequacy of screening.
Yeah, so until recently being maybe 2 years ago, there was no approved screening program for lung cancer to enhance early detection. But there were for breast, colon, and prostate. And there's one other thing to keep in mind, and that has to do with the heterogeneity of the disease. The histology of prostate, colon, and breast cancer, it's all adenocarcinoma. But adenocarcinoma only represents a subset of non-small cell lung cancers. And until not so recently, let's say 10 years now, we treated all advanced non-small cell lung cancers the same, regardless of whether they were adenocarcinoma, squamous, or large cell. Those are the components of non-small cell lung cancer. But now we have a better appreciation that they're different, and they respond to different treatments. So what we were doing in the past was having a homogeneous approach to a heterogeneous disease. Over and over again, we see that doesn't work. So that is another reason why survival rates are so low in lung cancer, and a reason why they're likely to get better as we go through the more precise approaches to treatment for lung cancer. So I just want to dig in a little bit on this concept of heterogeneity of lung cancer. So I told you about the histologies of non-small cell lung cancer, and there are 3 primary histologies now of lung cancer. There's adenocarcinoma, squamous carcinoma, and neuroendocrine tumors. Within neuroendocrine tumors lies a subset of small cell lung cancers. Importantly, there's heterogeneity even within these histological subsets. So for early stage lung cancers within adenocarcinoma, there are distinct subtypes of adenocarcinoma that are different histologically, different biologically, and different in terms of outcomes. And the categories of adenocarcinoma include tumors that are now called adenocarcinoma in situ. The terminology in the past, BAC, bronchoalveolar carcinoma, that terminology has since been discarded. And so tumors that are non-invasive are now called AIS cancers. Tumors with a little bit of invasion are called microinvasive cancers. On the other side of the spectrum are the solid adenocarcinomas that are quite active, fast-growing, very aggressive. That's a solid component. And then there are tumors that have both a mixture of a solid component and a component that is non-invasive. And those are called lipidic predominant adenocarcinomas. So that's the landscape of early stage lung cancer histology. But within advanced stage lung adenocarcinoma, we now think about molecular subtypes. Some of these adenocarcinomas harbor key molecular alterations that signify high rates of response to targeted therapies. And these key mutations and alterations include mutations in EGFR, include rearrangements or translocations of other genes, such as ALK and ROS1, and then other mutations that are less common that I'll mention a little bit later, such as in BRAF. We need to know these as we take care of patients who have or may have lung cancer. So I'm going to come back to the point that Dr. Seward and others mentioned in terms of early detection of lung cancer. So we have really strong data to show the benefit of screening for lung cancer in high-risk individuals. And the benefit was demonstrated in the National Lung Screening Trial. This is a really good study. 53,000 current or former smokers between the ages of 55 and 74 were randomized to receive either a regimen for CT screening of the chest versus chest X-ray. We already knew that chest X-ray was not helpful in screening for lung cancer, so in essence it's a placebo. And so the patients in this trial had an incidence study CT scan, and then they were followed with subsequent scans over the next 3 years. What was observed? On the top just shows the rate of detection of lung cancer. And as you would expect, and as has been shown in other screening trials, regardless of the modality, more lung cancers in the black line were detected in the screen group compared to the control group. That's not really so important. What's important is on the bottom. And the bottom is the cumulative number of lung cancer deaths, which was significantly smaller, or lower, in the CT group compared to the control group. And in fact, at the end of the day, there was a 20% decrease in lung cancer-specific mortality in these individuals who were screened with CT scan versus those who were not. And if that was not enough, there was an overall mortality benefit, not just a lung cancer mortality benefit, but an overall mortality benefit of 7% in those who were screened with CT versus those who were not. So this benefit is higher than other benefits demonstrated in trials for screening for breast cancer or prostate cancer, and is one of the highest mortality benefits you see in lung cancer, other than we know the mortality benefit comes from smoking cessation. So this is a home run. But despite this home run, there's always been and still continues to be a bit of skepticism about wide-scale implementation of CT screening for lung cancer. There are concerns about how hard it is to manage all the nodules. There are concerns that there are going to be too many patients being screened and it can't be managed or handled. And so it took a long time to wade through all these concerns and get to a place where lung cancer screening was approved. And so we put together a monologue here that addressed some of the concerns and the key issues that are important as we think about a future where we're going to be screening for lung cancer. Trying to address the potential barriers, trying to address the potential complications of screening, and try and suggest some avenues to improve the risk-benefit ratio and to make the screening more efficient and helpful. And so eventually, about 1.5 years later, CMS approved lung cancer screening for high-risk individuals. So Medicare reimbursement to be followed by reimbursement by private payers for individuals who met the following criteria. Criteria were age between 55 and 77, asymptomatic, of course, that's what screening is used for. They had to be current smokers of 30-pack years or recently quit smokers, and they had to have the following criteria. They had to have had a shared decision-making visit with a provider to understand the risks and the benefits of screening. And they also had to have their screening performed in a center that was approved by the American College of Radiology and which entered all their data into a registry so that we could, over time, evaluate the benefits of screening and determine whether there are opportunities to improve the efficacy of screening. So those were the criteria that were implemented, and lung cancer screening is now approved. Anybody know what the uptake is of lung cancer screening in the United States right now? What % of eligible patients, according to these criteria, have been offered lung cancer screening?
Less than 5%.
Exactly. Yeah, anywhere between 2 and 4%. So low, we'll call it low uptake. So yeah, let's explore some of the issues that come up as we think about lung cancer screening. And the first thing is, there's so many nodules. Oh my word, what do we do with these nodules? And so we have to think about, what are we trying to do with these nodules? The first question is this nodule benign or malignant? That's the first question we have to deal with. And so I'm giving you just examples of some nodules that can be encountered in lung cancer screening or incidental for that matter. Top left, How many of you think that, by show of hands, how many of you think this is a cancer? Top left. How many of you think this is benign? Almost every hand in the room. Me too. Bottom left, how many of you think this is a cancer? Me too. Yeah. So sometimes there are characteristics of these nodules that are really very helpful. Very smooth, round nodule, very consistent with a benign type of process, and a spiculated nodule that's big in the left upper lobe, and the patient looks like they have emphysema. That's going to be a high probability of cancer. Sometimes it's not so clear, like that top right. It could go either way. We'll call that more of an indeterminate type of process. But I would put forward to you, that's not the most important question right now in lung cancer screening, whether or not a nodule is benign or malignant, mainly because I think we have very robust tools to make that discrimination and to manage patients accordingly. But I think the more important or interesting question right now is for this cancer in the bottom right. And so the question really moves from whether this is a cancer or not, because I just mentioned it's a cancer, as to what can we expect for that patient within 5 years. So that gets us back to the point when we talked about early lung adenocarcinomas and the spectrum of histology. And what I want to show you here is that the survival of patients with early stage lung cancer is directly correlated with the histology of the adenocarcinoma. And so cancers that have histology of adenocarcinoma in situ can have 5-year survivals of 95 to 100%. Cancers that have a histology of microinvasiveness, and microinvasive is defined as less than or equal to 5 millimeters of basement membrane invasion, have survival rates around 95%. The survival rates for histologies with a more involved extent of invasion, they have lower survival rates. So this suggests that there are subtypes of lung cancer that have survival rates of 95 to 100% after resection, and therefore suggests that there are types of lung cancer indolent. To remind us a little bit of some types of prostate cancer that are quite indolent too. And that there may even be opportunities to think about strategies other than immediate resection for some of these cancers. And an observation may be a valid strategy. And the data that I just told you comes not only from our lab, that's what I showed you in the prior slide, it's on the top row here, but all around the world. Same experience. Non-invasive cancers having a very high survival rate. And in practice, this is shown to hold out as well. So here's a nice paper from radiology published by Claudia Henschke and David Yanikelovitz, who are at Mount Sinai Hospital. They lead the International Consortium for the Early Detection of Lung Cancer, ILCAT. And they are both leaders in lung cancer screening, and I think are in large part responsible for getting us to the place to understand that screening is beneficial and getting us to the place where it's approved right now. So they have a large experience of patients with big and small nodules and solid and non-solid nodules. And here's the experience in a large cohort of patients who had non-solid nodules. And the non-solid histology correlates with the non-solid appearance that we see on a CAT scan. So there were 1,700 patients that they were following, and eventually some of them showed some growth over time, and they were resected. 73 of these resected samples turned out to be lung cancer, and they were followed over time, as I just said, even though there was high probability, high certainty that they were a cancer anyway. So they were followed, then resected, all 73 resected, all 73 early stage, and all patients survived. So this suggested, doesn't prove, but suggests that a watchful waiting approach, an observation, may be a valid approach for cancers in patients who we can detect by screening. Very different world than the world I showed you before, where we have lung cancer survival rates at 5 years between 12 and 19%. Here we're showing a sub-cohort of lung cancer patients with 95 to 100% survival, and suggesting they may have that survival with or without specific intervention. So to me and to my group, this is a really interesting problem. And the problem becomes more interesting because some of these non-solid lesions will change over time. And a lot of us who've been doing this for a long time have seen these non-solid lesions develop a solid component, and that solid component can continue to get a little bit larger. And eventually, in some patients who come to our attention, those patients may already have metastatic disease by the time something is done about it. But by and large, most of these patients don't have that progression. So what is responsible for that progression, and how can we know whether or not a tumor at time A, B, or C is likely to change in time D, E, and F? So there is a progression of these tumors from this non-invasive stage to invasive stage. And we're interested in understanding the molecular processes that go on in those cells that cause them to become invasive. I'm not going to go over the individual studies that we've done, but we've looked at gene expression profile and transcriptomics, copy number alterations that are different in the invasive progressive cancers versus the indolent cancers. And a lot of our work is focused on the signaling that is differentially expressed for the TGF-beta signaling pathway. We've published a couple of papers on that, and we've shown that there are downstream signaling molecules that are differentially expressed, and at least in cells and in some animal models, we can show that we can alter the progression of these cancers. More recent unpublished data have been going on in our group where now we've taken a large number of adenocarcinomas representing that spectrum of non-invasive to invasive. We've done RNA-seq to understand the transcriptomes. And we can show again that there are specific genomic profiles that are different in the tumors that are invasive versus non-invasive, and that's shown over here in this group over here. Red means high expression of a gene, blue means decreased expression of a gene. Each column is a different tumor, invasive group versus non-invasive group. And we can take those signatures and apply them to published data sets of gene cohorts for patients in whom we know the outcome. And the signatures that we detected in our cancers are associated with differential survival of patients in other cohorts, looking at the same genes. And so whether it's a cohort from United States Director's Challenge or from the Tumor Consortium, patients who have a non-invasive signature in green have better survival, and patients have an invasive signature in red. And then we've also dug in, we want to understand what are the components of this signature. And so we've identified that there are specific genes that have amplification, that's increased copy number, that is different in cancers that are invasive versus non-invasive. Two of the genes are important in cell proliferation and in DNA repair maintenance, and those two genes are CDK4 and MDM2. And what I'm showing you on the bottom are results of a FISH assay. And in the FISH assay, we label the copies of the gene of interest in green, and we label the centromere in red. And so normally we should see 2 copies of a gene in every cell. And so in the non-invasive cancers on the right, that's what we see. But in invasive cancers, we see an increase in the green dots, if you will. And that tells us those genes are amplified. And so when we look at a large number of samples, we see that, yeah, the invasive cancers have a higher rate of amplification of both of these genes. And if we look at survival, patients who have amplification of MDM2 in particular in this yellow line, it's hard for you to see, but I can see it fine. Those patients have decreased survival compared to those that have a normal copy number. And we've gone on now to do other studies where we're in cells and moving into animals where we can try and inhibit the function of MDM2 and CDK4 and demonstrate that blocking those pathways can alter the progression of lung cancers as well. And so those studies are in progress and hopefully can lead to some potential therapeutic opportunities for patients with lung cancer. So the way we think about this problem is we know a lot about the potential activity and biology of the cancer by looking at the image. Those non-solid cancers tend to be non-invasive, and the solid cancers tend to be invasive. And that's what I'm showing you over here on the left. Some of these cancers will progress over time. So we think that combining the imaging features with the molecular features that can be acquired with cells obtained from a needle biopsy, and perhaps someday acquired by cells acquired from the blood, then together we can integrate those data and understand the probability of progression or lack of progression in particular cancer to help guide intervention. And that's particularly helpful in patients who have more than one cancer at the same time. And it's particularly helpful in patients in whom resection or other treatments may impose a significant morbidity. Now back to this nodule management issue, benign versus malignant. I told you that I think we're pretty comfortable with managing these. And in part we're comfortable because we have a large experience, and in part now we have nice guidelines that have been developed by several organizations. The most important nodule management algorithm is called LungRADS, and it's similar to what's used for breast cancer. It's called BRADS, and it's very good in helping to guide radiologists and clinicians in managing nodules detected by screening. And the way it works is that depending upon the cell, shown here under findings, and whether or not the nodule is solid or non-solid, that's associated with the probability of malignancy and a recommended follow-up interval. And so, in particular, to keep note of, we frequently see small nodules in patients who undergo screening. Well, if they're less than 6 millimeters in the screening cohort, there's no need to do any follow-up, and just the patient will come back as part of their screening regimen in 12 months. And so that takes the large number of the detected nodules out of the picture for any concern to do any kind of immediate follow-up. And for the non-solid lesions, that same approach of waiting for a year applies to anything under 2 centimeters. So I think these guidelines are very helpful and take out some of the complexities in managing patients who are undergoing screening algorithm. But I'll also just tell you that most nodules that we see, they come from outside the screening realm. They're incidentally detected nodules. And so we have guidelines to help us with that too. The most commonly used guidelines come from the Fleishner Society, and they're published just last year. And again, if there's less than 6 millimeters in a solid nodule and the patient's at low risk for lung cancer, meaning no prior history of lung cancer and a non-smoker, then there's no follow-up necessary at all. And similarly, we have algorithms for patients with subsolid nodules. So now, I told you one of the criteria for patients to be approved for screening to be covered by Medicare, they had to undergo a shared decision-making visit. The further stipulation is there has to be use of a visual tool during that shared decision-making visit. And here's an example of such a tool that may be helpful in explaining the benefits and the risks of screening the patients who are undergoing the evaluation process of whether they're going to be screened for lung cancer. This comes from the American Thoracic Society. And the point here is, on the left-hand side, let's say we screened 1,000 patients. We would detect overall 3 lung cancers in those 1,000 patients that we would not see if we didn't screen 1,000. But there would be incidental findings in patients, and there may even be biopsy procedures done in patients, and those biopsy procedures could lead to complications in patients. And that's highlighted in this diagram as well. So trying to explain the probability of a false positive or a nodule being detected and how that management may have an implication. This is an example of a tool that's being used. So a lot of barriers to undergo lung cancer screening in the United States, and a lot of concerns from the community, at least in the past, that related to a fundamental lack of certainty as to the benefit of lung cancer screening, which I think underlied a lot of the barriers that have been put in place for widespread implementation. And so, of course, one of the questions that comes, are the findings of NLST generalizable? And Now the answer to that is yes. And these data were just publicly revealed last week. So these are the results of a large trial that was done in Europe. This is called the Nelson trial, Netherlands and Belgium in particular. And so this is a randomized control trial. So 15,792 smokers, former smokers between the ages of 50 and 74, they were randomized to CT scanning versus nothing. And they were followed for over 10 years. Just like I showed you for, there were more lung cancers detected in the screen group in red versus the control group in blue. One of the goals of screening is to have a stage shift. Preferentially detect early stage lung cancers and then have a fewer number of advanced stage lung cancers. So this slide nicely shows you the stage shift that came from the Nelson trial. So the blue bar represents the screened patients. The green bar represents control arm patients. And the red bar represents patients who were not in the study but are in the Netherlands Cancer Registry, just to show you the generalizability of the findings to patients overall within this cohort. And so more early stage lung cancer is detected in the screened arm. That's here in blue on the left. And fewer stage 4 cancers are detected in the screened arm. So this is an example of stage shift. It's good. And you would think then this might translate into differences in mortality, and it does. So if you separate out men versus women, which is done here, and look at 10 years, within men, the survival benefit is 26% lung cancer mortality, a little higher than NLST. And in women, it was even higher, although fewer number of women then made this not statistically significant, but it suggested up to almost a 35% decrease in mortality of lung cancer for women compared to those who weren't screened. So this is like a second home run. It's like Aaron Judge had 2 home runs. So the findings are, so for Nelson, men at high risk for lung cancer have a reduced risk if they're screened, and women maybe even higher. These support and maybe even are better than what we saw in NLST. And so again, this supports generalizability of lung cancer screening as an effective modality to improve lung cancer mortality in high-risk individuals, and I think should make us more urgently look for solutions to increase the uptake of lung cancer screening for our patients, for whom it will be of benefit. Just to help in that process, the American Lung Association and the American Thoracic Society partnered together to put forward recommendations and algorithms on how to develop a lung cancer screening program, how to staff it, how to fund it, and then how to operate it using the experience of about 15 centers throughout the United States that have successfully done it. And it's available online. And we're fortunate at Mount Sinai to have one of the largest and one of the best screening programs in our health system. And I encourage you all to use it. As you probably know, there are tools within Epic to make the process of referral easy. And if you have any questions about it, we can put you in contact with those and make it very easy for you to get your patients what will likely be a benefit to them. So now I'm going to shift gears a little bit from early detection and early stage lung cancer to focus on advanced stage lung cancer. Because it's important for all of us to know, whether we're oncologists or not, internists, pulmonologists, regardless of specialty, you will encounter patients in whom you will make a diagnosis of lung cancer. As that diagnosis is entertained, it's important to know and to counsel the patients about the changes that have gone on in lung cancer now, to take a disease for which there was a nihilistic approach 10, 15 years ago to approach now, which we feel optimistic about the options available to provide a response that's meaningful to our patients. So it's really changed our approach to lung cancer. We need to understand a little bit about the how and the why. And so we know that there are multiple genetic changes that go on in cancers, and that in lung cancer there are specifically some changes that are important to help understand the response of specific lung cancers to treatments. And the ones that are the most relevant at this point in time include mutations in genes such as EGFR, which is seen in about 10 to 20% of lung cancers that are resected in the United States or Western Europe, but at a much higher prevalence in patients who are from Asia. And then the ALK translocation for patients is about 5%. Also, to keep in mind, there are patients who have a translocation of another gene called ROS1, who are sensitive to the same medications as patients with an ALK translocation. And then there are patients with a mutation in BRAF, and there are recent data now to show that combination targeted therapies are a benefit in that population too. Notice, this is all adenocarcinoma. There are no red circles for squamous carcinoma, and there are no red circles for small cell carcinoma. So there are many molecular alterations that are unique to those histologies, but we haven't yet gotten to the point to know whether there are specific key alterations that are targetable by new therapeutics for those cancer types as of yet. But I predict that if and when you invite me back in a couple of years, we're going to have some red circles in those columns too. Just want to say that it's important for us to know about this, and important for us to know about the clinical relevance of this, which I will cover in a moment, because we know that there's some gaps in how often and how quickly patients with lung cancer are referred on to specialists. And here's just a paper that was published last year that showed that amongst patients who were seen by generalists who had a diagnosis of cancer, only 20% made it to an oncologist for treatment within a period of 8 weeks. And in part, that's because, potentially because, of that nihilism that may still persist in some of the communities amongst patients and providers, where they don't think there's any hope if they have a diagnosis of advanced lung cancer. But trial after trial and study after study shows that even for patients with advanced lung cancer, even if they don't have a targeted alteration, outcomes in terms of quality and duration are better in those who receive treatment for their cancer versus those who don't. So it's important to keep that in mind. So I just want to show you a little bit about what the promise is for our enhanced understanding about the biology of these cancers. And it really starts with the story that has been unraveling with the EGFR mutation, for which I told you the prevalence is 10 to 20%. When there are mutations, they tend to happen within exon 19 and 21. And if in patients who have tumors that have this mutation, their response rate to drugs that target this gene, and these genes are called tyrosine kinase inhibitors against EGFR, the response rate is 70%, which is much higher than the 30% rate to standard conventional chemotherapy. So outcomes are improved in patients whose tumors harbor EGFR mutations if they're treated with a tyrosine kinase inhibitor. Part of the reason we know that is from several large studies, such as the one that I'm showing you now. This is called the Icahn study. This isn't the largest and maybe not even the best, but I think it illustrates key points that are relevant for us. So this was designed to randomize patients in Asia who had a high demographic risk profile for harboring an EGFR mutation, meaning they were enriched in women and enriched in non-smokers. And they were randomized to receive the standard of care, which was a platinum doublet chemotherapy regimen versus a tyrosine kinase inhibitor targeted EGFR, and gefitinib was the drug here. There was no screening done for mutations for entry into this trial. And if we look overall, there was a survival benefit in terms of progression-free survival, not overall survival, in patients who received gefitinib versus those who received combination chemotherapy, top left. But I think there's really important information about the relevance of the EGFR mutations shown in the top right. So some of the patients had mutation analysis done. Most hoc analysis, survival was evaluated in patients whether they had an EGFR positive mutation or whether they were wild type for EGFR. The top right shows you the results in patients who had an EGFR mutation in their cancer. And so patients who had a mutation had improved progression-free survival if they were treated with gefitinib versus standard chemotherapy. So then one might say, okay, we have a group of patients who have risk factors suggesting they have an EGFR mutation. And if we treat them all with an EGFR mutation, we're going to do well by all of them. Well, that doesn't necessarily hold water. And the reason we know that is because we have data on the patients who are wild type for EGFR on the bottom left. And so for the patients who are wild type for EGFR, their progression-free survival treatment with gefitinib was worse than if they received double chemotherapy. So this really reinforced the importance of evaluating patients for the presence of the target, in this case EGFR, and using the targeted therapy only for patients in whom the target is present. And that has led to the state of affairs here in the United States, where we have targeted therapies approved with concomitant approval of correlative diagnostics. And the approval is contingent for many of these targeted drugs on the patients having a mutation for which the drug is intended. This is the study that really underlies the rationale for that approach. So EGFR is the first example. Similar data come from translocations in other genes, like ALK, for example. Here, there's another FISH analysis, but it's called a break-apart probe analysis to detect the translocation. Patients in this phase 2 trial who had ALK translocations, who failed other treatments for non-small cell lung cancer, who received crizotinib, that's the ALK inhibitor, they did really, really well in terms of response rates when treated with crizotinib. These data were confirmed in a phase 3 trial. But we have to appreciate that there's some limitations to these exciting data with regards to responses to targeted therapies using tyrosine kinase inhibitors. First thing to keep in mind is the endpoints that I showed you in these trials and all trials that have subsequently been performed. The endpoint is progression-free survival, not overall survival. And we have to think about why that might be the case. There are a couple of potential reasons. One is that many of these trials had some crossover. Patients who might have been assigned to the placebo arm got crossed over to the therapeutic arm by their oncologist. That's one possibility, and crossover did happen. And the other possibility is that almost every patient over time develops acquired resistance to these drugs. So a lot of effort now has gone on to understanding how that happens. And so we know that there are specific acquired mutations in EGFR that cause resistance. We know that there's activation of other signaling pathways that cause resistance. And now new drugs have been developed to try and bypass those mechanisms of resistance. So now we have second and third generation drugs within the tyrosine kinase inhibitor class. And now we've evolved to a process where patients who are being treated with a tyrosine kinase inhibitor who develop resistance then may be treated with a second or third generation or another drug depending upon what the mechanism of resistance is. Just to show you, this is a second generation ALK inhibitor, which in patients who had resistance to crizotinib or not, did much better in terms of response rates after they failed prior therapy. So now we're moving to a world where if we don't understand why the patient is not responding, many patients will have another biopsy done, and that biopsy will detect the mechanism of resistance and then guide treatment with another drug. So this is really a case report that was published in the New England Journal by the Mass General Group, a leader in the treatment of patients with advanced cancer, especially ALK-positive cancers. So this is an ALK-positive patient treated with crizotinib, just like we discussed, developed resistance, had a biopsy done. Biopsy showed a specific alteration. Prior work done in lab studies showed that patients with that specific alteration would be responsive to another drug called lorlatinib. Patient was treated with lorlatinib, had a nice response, but over time developed resistance to that. Patient had another biopsy done, and then the tumor was shown to have an alteration that was now sensitive to crizotinib. Crizotinib was reintroduced, the patient had a response, and subsequently, unfortunately, expired. But this is a pathway and a program of treatment that is ongoing at many thoracic oncology programs to continuously manage these patients and provide them with survival that is much longer and better than would have been possible before. And so Roy Herbst published a very nice review in Nature just last year that summarizes the progress in the field, and a very nice table to show you the options and first-line treatments for advanced stage lung cancer now. And so the drugs that I showed you up front, those are first-line drugs. But now we've moved to the point where we have really terrific third-generation drugs. For EGFR, it's osimertinib, and then for ALK, it's alectinib. And there's some data to suggest that these drugs are superior to the first-line agents, even in upfront first-line setting. So these drugs are approved for and often used now for the treatment of patients with EGFR mutant cancers and ALK translocated cancers, rather than the first-line agents. Now, the response rates to these tyrosine kinase inhibitors is high, but the prevalence of these alterations is low. So there's still many patients with advanced lung cancer who don't fit into the category of having a targetable alteration. But now there's nice therapeutic options available for them too, and many of them come from treatments that are targeting the immune checkpoint cascade. So the way this works is that tumors are foreign in our body, and our immune system is typically able to recognize foreign proteins and to engineer a T-cell mediated response to them. But we also have active systems to try and damp down the response of the immune system to foreign proteins, and that's to reduce the probability of autoimmunity. And there's one such mechanism, which is the checkpoint mechanism within T cells that requires binding of a receptor on T cells, which is the PD-1 receptor, programmed death 1 receptor, to a ligand expressed on a foreign protein. And when that receptor is engaged by the foreign protein, the immune response is damped down, checkpoint. Well, cancers take advantage of this checkpoint by expressing this ligand on their cells at times. And when they do that, the immune system response is diminished. And so now drugs have been successfully developed to inhibit the binding of the ligand to the receptor for the checkpoint mechanism. And these drugs are directed either at the receptor, and two drugs that do that are nivolumab and pembrolizumab, and drugs are also targeted to the ligand. These are more recently developed drugs. They work. So this is the first trial that shows the efficacy of the PD-1 receptor antagonist, nivolumab, versus standard chemotherapy in patients who had advanced squamous cell non-small cell lung cancer who had failed prior therapy. And what it showed was that in these patients who were treated with the checkpoint inhibitor, survival was better. Here, it's overall survival, not progression-free survival. And so the field has moved on. So now, there have been several large-scale trials done in the second-line setting, such as what I just showed you previously, and now in the first-line setting, that show the efficacy of these drugs. In squamous cell carcinoma and non-squamous cell carcinoma, that advanced disease, and more recent trials that show the efficacy of this regimen in lung cancer stage 3 disease. But the field really has evolved to the point now where we consider treating all patients with advanced lung cancer with these drugs, regardless of whether they express the PD-L1 ligand, which was a criteria for use of these drugs in the first-line setting previously. So this trial that really helped to move this forward was published just earlier this year, after the ASCO meeting. And so here, patients with advanced non-squamous lung cancer in the first-line setting were randomized to receive pembrolizumab and chemotherapy versus chemotherapy alone. And the trial showed that overall survival was better, significantly improved, I should say, in patients treated with the checkpoint inhibitor plus chemotherapy versus chemotherapy alone. And this was regardless of the level of presence of expression of PD-L1 in the tumors. And just yesterday, the New England Journal published a paper that showed the same impact on patients with squamous cell carcinoma. So now we're moving to an era where patients with advanced lung cancer will be considered for upfront treatment with checkpoint inhibitors as part of their chemotherapy regimen in the first line as standard of care. This is a marked change from the way we treat patients with lung cancer. We also have to keep in mind, as we use more and more of these checkpoint inhibitors, we have to keep in mind the toxicities. And really, these checkpoint inhibitors are associated with a wide range of toxicities. To put it bluntly, it's really itis of any organ. Hepatitis, pneumonitis, keratitis, gastroenteritis. And one that we are typically most concerned about is pneumonitis in the lung. And so patients who are treated with these checkpoint inhibitors can have a frequency of pneumonitis ranging about 5% if they're treated with just one immune blockade drug versus up to 10% if they're treated with combination immune blockade drugs. And the pattern of pneumonitis can be similar to any pattern of interstitial lung disease that we may see. So we have to be very cognizant about this possibility, be very quick to evaluate patients who have symptoms suggesting the presence of pneumonitis, to withhold therapy at the first sign of pneumonitis, and for patients that have more moderately severe pneumonitis to treat them with steroids. We know from experience that this is manageable and can be successfully managed if it's detected early and treated appropriately. And this review was in Journal of Clinical Oncology not too long ago, helps us spell out suggested regimens for dealing with this issue. So in summary, lung cancer is a heterogeneous disease. It's caused by the differences in biology, and these differences are reflected in clinical outcomes. Lung cancer screening is effective. I don't think there's any reason to debate that anymore. And so it's important for us to make this available to our patients who are at high risk. Tumor-directed targeted therapy in lung cancer works when we target the targeted therapy to patients whose tumors harbor the target. Acquired resistance happens, it's manageable. And immunotherapy is very effective. It's really now emerged into the standard of care. There are some complications we need to be manageable too, with appropriate recognition and treatment. So we've moved from a world where I think there was appropriate nihilism in lung cancer to one which we're appropriately optimistic about the future for patients with lung cancer in terms of early detection and treatment for patients with advanced cancer. Thanks so much.
Questions?
Yeah,
There's a question.
That was a wonderful talk. It was really very illuminating for me, and I'm sure for most of us. But I'd like to suggest a refinement to that patient-provider shared decision-making, and that is to add age and comorbidity. Because obviously, if you guess wrong in a 50-year-old, there's a lot more to lose than if you guess wrong in an 80-year-old. And the risk of intervening in a 50-year-old is much less, and the risk of intervening in an 80-year-old is much greater. Comment on that?
Yeah, I agree. I think age is important and comorbidities are certainly important. Screening will not be effective for a patient with multiple comorbidities that are going to restrict their 5-year survival rate with or without screening. And screening shouldn't be offered to patients on whom we cannot offer a benefit. So we have to take that into account. I agree fully.
And the age.
Age as well. But you know, there's some young patients who have a lot of comorbidities and some older patients with fewer. And so we have to take both into consideration. Right now, the age criteria are 55 to 77 for lung cancer screening. Oh, sure.
One follow-up question. I just learned yesterday, apparently, that at Mount Sinai, or the Icahn School of Medicine, it is now frowned upon to identify ethnicity or race in the initial presentation. I think, coming from an old school, that's foolish, because race and ethnicity can be a heuristic that helps you identify the right way of progressing. And your slide about the high incidence of, I think it's EGFR in Asian populations is a very good example of that, because it initially tells you, gee whiz, this patient may have a resistant lung cancer, just on the basis of ethnicity.
So I support the concept that there are differences in disease presentation and outcomes and response to treatment according to many factors that include race and ethnicity. And taking that into consideration is helpful.
Do you think that new data that came out about the survival of the stage shift will impact that screening form where it shows people that are impacted to survive? Because it seems like there's a much larger benefit with the new data compared to the data where that screening assistance came from. In terms of like the 3 people that were detected and the people that had complications, since more cancers were detected early, there's a better mortality benefit that we're finding. So do you think that's going to change in terms of the shared decision making?
Yeah, I hope so, because the concept for screening is by finding those cancers early and intervening on them, we impacted their outcome. There are some cancers that are so slow growing that if we remove them, we might not have an impact on their outcome. That process is called overdiagnosis. It exists in prostate cancer for sure, and maybe in lung cancer. And the way to know the impact of overdiagnosis is through a randomized trial, just like it was done in NLST. That takes into account whether or not there's overdiagnosis, and that trial did show that patients who had early detected lung cancer had better survival. So that's the message that needs to come through when going through a diagram like that, which is suggested.
The St. Luke's site, can you hear us?
Yes.
Thank you, Johnny, for a beautiful presentation for a very complex topic. But I wanted to know what are the criteria of more comorbidities and how do you explain that to patients? The other is many people have perceptions of 5-year curative rate on the every disease at 8 years or 9 years. So they survive enough to get the second which may actually make their life. So how would they be managed under these circumstances? I mean, because 5 years survival doesn't equal cancer free.
So for the first question had to do with the comorbidities and talking with patients. I think that for patients with comorbidities, that's when the shared decision-making visit really becomes helpful. Patients need to understand that if their disease that they have is going to be associated with short outcomes, short survival, then they're not going to get any benefit from screening, and it's important for them to understand that. Typically, a nice surrogate we use is whether or not we think a patient can tolerate lung cancer surgery. That's a good surrogate for the extended comorbidities a patient may have. If we think a patient, even if they carry diagnosis of heart disease or COPD, they can tolerate a lobectomy or a wedge resection, and those patients typically could be considered to be eligible for screening for lung cancer. So that's a rough cutoff, ability to tolerate resection for cancer. As far as the other point, lung cancer sure can recur in patients. It's not clear whether what we're seeing in patients who had lung cancer in 1 year versus those that came back in 9 years is recurrence of the first cancer or development of a second primary attributable to the same risk factors that led them to get the cancer in the first time. And so certainly it would suggest rationale for following those patients carefully over time. So if they did develop a second cancer, detect it early. So I think that's the way to manage that issue.
So when thinking about immunotherapy, I've heard the paradigm of mutation burden in terms of 2 different tumors. Is it the case, correct me if I'm wrong, that squamous cell carcinoma has a high mutation burden? We don't know which specific mutations, as opposed to adenocarcinoma when we have targeted GFR or off therapy? And I have a quick second question as a future radiologist. How do we consolidate between Lung-RADS criteria and Fleischmann criteria? I know one is incidental versus one is screening, but is there going to be a future change consolidating both of those?
So yeah, good question. So the first one was talking about immunotherapy and mutation burden. Studies had shown that patients whose tumors had higher expression of the PD-L1 ligand had a better response rate, better outcomes if they were treated with immunotherapy before. Similarly, there were studies that showed patients whose tumors had a higher mutation load had a better benefit with immunotherapy versus those that had a lower load. There are certain histologies that are associated with different mutation burdens. Squamous cell is higher than adenocarcinoma, and small cell carcinoma, for that matter, is higher than all the other cancers. But yet, we still see uneven responses according to all those histologies. But I think the theme that emerges is that the higher the presence is of new antigens, the higher the response rate is. And that's why perhaps these studies that combine chemotherapy with immunotherapy are effective, because you're taking these cells and you're killing them with the chemotherapy. They're releasing all these proteins. They're going to engage the immune system, and then the immunotherapy can help reinforce that process. So I think that's what's going on. And I think that's why using concomitant chemotherapy and perhaps moving into radiation therapy will help accelerate that a bit. And the second question is, I don't think Fleischner and Lung-RADS necessarily aim to merge over time, because they deal with different types of patients. Incidental nodules are in high risk and low risk patients. And there's no automatic fallback of a 12-month scan in patients in the incidental setting as opposed to those in a screening program. But I do think they're both going to evolve over time. The Fleischner criteria that were published last year represent a change over prior version that was published 5 years and 10 years ago. And they're going to continue to evolve as we get increasing experience, and so will Lung-RADS. I don't know if they'll ever be the same, but they will change. Grace.
I think that talk was really interesting. I was wondering if you could respond to some of the criticisms of precision medicine. So the nivolumab. I had read the average survival was about 3 months longer than the standard treatment. And nivolumab, it seems like costs like $200,000 and $14,000 a month, which really impacts like state Medicaid budgets. And then the other criticism I had read recently was that studies like IPASS are conducted in low resource countries where it's not really ever realistic that the patients there would take it. And is that ethical when they don't have the resources to pay for that medication after the study ends?
No, so those are loaded. All right, so first one first. The duration of survival benefit is important to think about. And the United States is a rich country. So we, as opposed to other countries, we can afford to think about having treatments available that can provide high quality, longer life to patients. And just to reinforce that, there was a nice piece in the New England Journal last week by Jeff Drazen, when he wrote about the experience of his brother, who was diagnosed with metastatic colon carcinoma. Not curable, but he went through a couple different rounds of very aggressive treatments and was able to have prolonged survival of good quality that was meaningful to him and his family. And I think that tells us a little bit about the human and personal experience that is involved in cancer, and shows the potential benefit of those months of high quality survival for particular cancer patients. Not every country can afford it, but we can. And so if we can demonstrate improvement in prolonging quality of life survival it's a good idea. As far as the cost, yeah, the cost of these drugs is high. It costs a lot to develop these drugs. Over time, they move into generics, and generics are pretty cheap. And if we look at the cost of drugs overall in the United States, in the aggregate, it has not increased a heck of a lot, mainly because most of the drugs we use are generic right now. And so there are certainly some drugs are very costly, but most of the drugs are really cheap. And so the amount of money that we spend on drugs right now has not increased a heck of a lot. So another reason why we can afford it. The second point is really good. So right now, in lower resource countries, such, let's say even China now, immunotherapy is not yet available. Nivolumab will become available in the next couple of months. None of the nivolumab trials are done in Asia. The tyrosine kinase inhibitors, those drugs were available in China right off the bat, and available in the East right off the bat. So I also have trouble with ethics of doing trials of therapies in low resource countries that would not be able to provide the drug afterwards. But for these examples, it hasn't happened. But I agree, it's important to be mindful.
I just don't understand the relationship of surgery to these types of therapies, immunotherapies. Like, for instance, I'm usually dealing with people where a lung resection would be a questionable, reasonably questionable, even in the face of having a tumor that obviously needs to be resected if the patient were younger or healthier. So what happens with these patients? Do you resect these? Can you, from a biopsy, from a bronchoscopic biopsy or a needle biopsy, can you get all the genetic information you need to try these different kinds of therapies? What's the relationship with surgery in your studies here? Did all these people have a partial resection?
So surgery is the primary modality for treatment of patients with early stage lung cancer. But there are alternatives. And the best alternative right now is stereotactic body radiation therapy. That works really, really well. And in some studies, the outcomes of patients who receive SBRT are very similar to patients who receive surgery. And so that's a really terrific modality that can help patients with early stage lung cancer for whom resection may not be possible. We don't have any data on use of targeted drugs or immunotherapy in early stage lung cancer as of yet. There will be some trials that investigate these drugs in the adjuvant setting for patients who've had treatment of their primary cancer as a means of reduce recurrence or second primary cancer. We don't have any data yet in that setting for those drugs.
Captain, thank you very much. It was really great.